Good day everyone. This presentation is about the NIH stroke score or the NIH. It will be presented as concisely as possible. Please, pause here and get a paper print of the NIH stroke scale and review it before continuing. First, review it then continue the video. Follow the video with the actual paper print of the scale. You will get the maximum benefit out of this presentation, as you will notice there are some overlaps in some of the items, and that is an intrinsic part of the NIH stroke scale, and the neuro exam in general.
The NIH stroke scale is the standard bedside neuro exam across the United States for the determination of the acute stroke. So, it is very important that all healthcare providers are well versed on it. This is what this presentation is about. To sharpen your NIH stroke scale skills. This is one of your superpowers.
The first item is the level of consciousness, and the questions are, 1. Is the patient alert? Is the patient able to attend to the environment? And based on those items you're able to score the patient on item number 1. See. This is easy.
The following item is about asking patients 2 questions, 1. What is the month? And 2. What is your age? The patient is not provided any help, and only the initial attempt is scored.
The next item is about following commands, so the patient is given the commands, 1. Open and close your eyes, and 2. Make a grip and open hand. Partial attempts are okay, but you only score the first attempt.
The following item is the gaze, the horizontal eye movements. You ask the patient to look to the right, look to the left, and then based on that evaluation and observation you are able to provide the score. Easy peasy.
Next are the visual fields, where you present the patient with 1 or 2 fingers in the 4 quadrants of the visual fields, 1 quadrant at a time. Not too close, not too far, about 2 feet from the face. Fingers you are showing in each one of the 4 quadrants. If the patient is not able to count, then you can do visual threat to both eyes, incoming from each one of the quadrants.
The following item is facial weakness. Ask the patient to show the teeth, and to raise the eyebrows. The score is for symmetricity.
The extremities strength items are scored for left and right sides, individually. Each one gets a score. The first item here are the arms. Have the patient raise the arms 90 degrees if the patient is sitting, or 45 degrees if the patient is supine. Better if the palms of the hands are up. The patient keeps the arm at that level for the next 10 seconds as you can count for the patient, so that the patient knows what it is that you are doing.
The following item is the strength of the lower extremities. Again, left and right, and with the patient laying down, then the lower extremities, one at a time, come up about 30 to 45 degrees. The patient keeps the load for a count of 5 seconds, and then you repeat for the other side.
Next is ataxia. You ask the patient to touch her nose and then touch her finger, placed at arm's length from the face. Then, slide the heel up and down the shin, one side first, then the other. A single score is provided if present on either side. Only score if the ataxia out of proportion to the weakness. Bears repeating, only score if the ataxia out of proportion to the weakness.
The next item is the sensory, for which you use a pinprick. You touch each side of the face, the arms, the trunk and the legs, left and right side, and then you provide a score based on your findings. You are looking for asymmetry of sensation. Is numbness present somewhere? And how deep?
The next item is language. Here you will have the patient name items on the printed paper sheet that belongs to the NIH stroke score. The patient reads the sentences on the sheet, and describes what is happening on the picture with the cookie.
Next item is dysarthria, where the patient reads or repeats words from the sheet, such as mama, you know how, and thanks.
Lastly, extinction. This is performed with the stimulation on each side, left and right individually, and then both together, or simultaneously. It is scored as present if when stimulated together the patient is unable to detect the touch on one side, in which case, you score if the patient is extinguishing or neglecting one side. This is done with sensory and vision. Provide a score if 1 or 2 modalities are affected.
Score the best score for each item. Note that the higher the total score, the more proximal the occlusion, and the larger the stroke, and therefore the more severe the stroke. The range of scores goes from 0 to 42. A stroke of 4 or less is considered a minor stroke. The NIH stroke is used to determine the severity of the stroke, and to support the therapeutic decision-making within the first 24 hours.
In the window from 0 to 3 hours, any deficit is considered for intravenous alteplase.
In the 3 to 4.5 hours window, the NIH should be between 5 and 25 for consideration for intravenous alteplase.
In the 0 to 24 hours, any score of 6 or greater, or severe aphasia or severe hemiparesis, should be considered for endovascular therapy. Patients may be able to receive intravenous and intraarterial therapies concomitantly.
For intraarterial therapy, the modified ranking scale is included in the decision-making, and the score will be 0, 0, 1 or 2.
Not all will be always smooth sailing. The least reliable portions of the NIH stroke score are ataxia, face weakness and sensation. A little extra attention here.
This testing is not very sensitive for the posterior circulation, for which you have to consider other elements outside of the NIH scores, such as diplopia, eye misalignment, dysmetria, nystagmus or decreased level of consciousness.
It is also a challenge when the patient has more than one acute strokes occurring at the same time, for example a shower of emboli coming from atrial fibrillation, where the patient gets multiple strokes at the same time. Also, when the patient has old strokes and you don't know the type or magnitude of the prior deficits. So, you tried to weed out what is old and what is new, to provide an acute NIH stroke score. Further, if the patient has had an old stroke, other things besides another stroke can lead to increased deficits, such as infections.
Todd's paralysis is that paralysis that occurs after the patient has had a seizure. It is a temporary paralysis due to the effect of the seizure on that involved brain. It can mimic a stroke. As you can imagine, that requires training and experience to be able to discern one from the other. Deliberate to improved skills.
Another condition that can mimic a stroke is complex migraine. These patients typically have headache, but there is such thing as migraine without headache.
Fairly common in clinical practice in emergency rooms are involuntary and unconscious conversion or functional disorders, where the patient has a stroke mimic or stroke-like spells that look like a stroke, but there is no ischemia to the brain. It is due to factors in the psychosocial realms. These are real conditions, and real challenges that deserve our full empathy.
When in doubt about the score, just opt to leave a detailed comment in the notes about your findings and your questions about what has occurred. That, my friends, is a concise review of the NIH stroke score. Please, review the disclaimer in the description below. Thank you very much.